So I'm going to start by talking about pediatric asthma. I want to make this interactive. It's going to be a case-based, so I hope y'all will interact with me and make this more fun. When I was putting the slides together, someone asked me who the baby was, and this is my 14-year-old now. So when I first started doing this talk, he was about 1, and so it just tells me how old I'm getting and how quickly time goes by and stuff. But when I moved here, he was 3 years old and stuff, but now I have, my oldest is 14, my youngest is 3, so I go from doing biology every night to playing and doing diapers with the other one, so it's a very interesting household. So this, how many of you have patients that do this, okay? This is, I went to Washington, D.C. this past summer, and how many of y'all have been to the National Stamp Museum? Anybody? Oh, we got one. It's actually a Smithsonian. Many people don't know that it's a Smithsonian. It's in the old post office. And one of the rooms they have in this museum is pretty cool. Is they, 15, 20 years ago, this guy asked people to start mailing postcards to him of unconfessed secrets. And so in this room, they have all these postcards up of unconfessed secrets. And this was one of the postcards that was in the room, okay? And the postcards are anywhere from funny to real sad. I said, my dad died and I never got to see him again or something. But there's all kind of stuff in this room. So it's really neat. But this is just one of the ones that was up in this room. Here's another one. This goes with Dr. Roop's talk. My children have food allergies, and sometimes when I have some candy I don't want to share with them, I'll lie and tell them it contains something they are allergic to. So not very nice, but it does work very well. All right, so we're going to get to the case now. So I have a 3-year-old black male who complains of coughing and shortness of breath for the last 6 months. Patient typically gets worsening symptoms with upper respiratory infections. Patient has been diagnosed with reactive airway disorder in the past. All right, past medical history, the child has had recurrent otitis media and sinusitis, doesn't have any known allergies. So my question is, I think we have some pediatricians and family doctors in the room who see kids a lot. How do you diagnose asthma? How do you diagnose asthma in your office? Who's going to be brave and diagnose asthma? Does this kid have asthma? Give him a nebulizer treatment. How's that going to help, Dr. Worsham?
Give him bronchodilate.
Bronchodilate. Okay, but let's go back.
If he's acute, if he just says he's coughing.
Okay, so do you think this one has asthma or not? Good. So if you didn't hear him, he said, ask about family history. And if they have a history of asthma, that increases their risk for asthma. So that's one thing we're going to talk about. That's a good point. What else? How else do you decide if this kid has asthma or not? Let me take a poll real quick. How many of you feel like he has asthma? Raise your hand. How many of you wouldn't diagnose him with asthma, would still call him reactive airway disorder? Okay, we got someone to do that. Okay. Turns out the same way, he says. Okay. How else? How would you decide if you were going to call it asthma or not? Anybody else? Send them to me. Okay, I like that. Great. He's an audience plant. Okay. One of the questions that we always get from pediatricians and stuff is, how do you decide to send a patient with shortness of breath, wheezing to an allergist or a pulmonologist? And I tell them it's an easy answer. You send them to the allergist, of course, right? But one of the big differences between an allergist and a pulmonologist, pediatric pulmonologist especially, is one thing is that we see kids from the cradle to the grave, like a lot of you family doctors. We start seeing them when they're 1, and I have some kids now that are 14 or 15 that I started seeing at that point. And it's real neat to follow them that whole way through because they change a lot. Some get better, some get worse, some stay the same. So that's one thing I think that we're different, is that we sometimes follow them into adulthood. I think the other thing that's different is that one thing that I think we do better than the pulmonologists is that we look for causes of asthma. I think allergists, how we look at us as Sherlock Holmes. We like looking for what's causing the asthma. We're not just going to diagnose them, but we're going to say, hey, are allergies playing a role? Are viral infections playing a role? And try to get to the bottom of what's causing the asthma so that hopefully, if we can figure that out, they're going to get better. So, that's one other difference. I think the pediatric pulmonologists, sometimes they see the more severe kids with asthma, the ones that end up getting hospitalized and intubated. which are fewer and fewer, thank goodness. But I think those are a couple of differences. Anybody else? How would you diagnose asthma in this one? What would you do? Anything you would do to help figure this out or not? Great. So nighttime awakenings. How often are you having symptoms? Anybody else? It's a great point. She says that if albuterol helps, that's a good sign that it may be asthma. If they are only getting symptoms with respiratory infections, it may not be asthma. If they get it at other times, maybe associated with allergies, more likely to be asthma. Good. Anything else? Frequency. So how often? So I agree with you. The more often they're having this, the more likely it's probably asthma, not just reactive airway disorder. And then what we mean by reactive airway disorders is usually just associated with viral infections. All right, so let's keep going. So the definition of asthma is a chronic inflammatory disorder. You know, when I was coming through med school, we were starting to go more in that direction. And, you know, originally we talked about it just being bronchoconstriction. You know, albuterol helps, opens up, is a bronchoconstriction disorder. But what we found is the reason they have asthma is they have some type of inflammation. And what we realize with most people with asthma is that they're very different. Some people have eosinophilic inflammation, some people have neutrophilic inflammation, but the type of inflammation can be very different in different types of asthmatic. But in general, they have some type of inflammation that's triggering their symptoms. And this contributes to their reversible airway disorder. So when we give them albuterol, what happens? That's what, they bronchodilate, and if we're able to do spirometry on them, the definition is that they improve by 12% and 200 cc's on their spirometry. So that's what reversibility means. So it's a reversible airway disorder. Also, you can have bronchial hyperresponsiveness, and what that means is that different things can trigger their asthma. So allergens can trigger their asthma, viral infections can trigger their asthma, cigarette smoking, smells, there's a lot of things that cause them to have more bronchial hyperresponsiveness. And again, this contributes to their symptoms and how bad their disease is. One of you brought up that asked about family history, but what for kids especially is atopy is the strongest predisposing factor in the development of asthma. So what does that mean? Atopic means that you have a genetic predisposition for allergies. So if you have a kid and you do allergy testing on them, whether it's skin test or blood work, and you find them to be allergic, the likelihood goes up dramatically that this is asthma. So this is one thing that can be very helpful in figuring out, you know, if this is asthma, not whether or not they have asthma. What are the other two atopic diseases that we think about that kind of go into triad with asthma in a lot of these kids? Eczema, so atopic derm, allergic rhinitis. We have, I like recognizing people and embarrassing them a little bit, but we have Dr. Hill, wave Dr. Hill, and Dr. Son in the back, they're both dermatologists, so they see atopic dermatitis all the time, like we do. And if you have a kid with atopic dermatitis, you need to think about asthma. So you have this kid, atopic dermatitis, they're coughing all the time, it's probably asthma. They got about a 30% chance of developing asthma if they have atopic derm. So again, you want to keep that in mind in a kid that has atopic derm. Other things that cause asthma problems in kids are viral infections. So RSV is very common, rhinovirus is very common. You see a lot of kids that get RSV and then they have asthma for the rest of their life after getting the RSV. So there are some kind of triggers causing this inflammation, chronic inflammation after getting a viral infection. Pollution can be another thing that can trigger asthma. So they have good studies showing now in kids that live beside big highways or in big cities that they are at increased risk for developing asthma. So pollution, we know, can contribute to this. What do I mean by gene and environment? We know there's probably over 50 genes that can play a role in developing asthma. And with having these genes, if you get exposed to a certain environment, it can trigger the asthma. That's what that means. Also, secondhand tobacco smoke. I love when I see a kid and I ask the parents, do they smoke? And they say, no, I don't smoke around the kid. Like, that's not going to cause problems. But we have good studies showing that, you know, if you have smoke on the clothes, smoke around the kid, that can indeed cause problems for the kids with asthma. We're getting more and more data with obesity, especially in kids. You have this obese child that walks into the room having problems with asthma. You get them to lose weight. A lot of times you'll see a big improvement in their asthma. And then there's questions about daycare. Does daycare and being around a lot of viral infections increase your risk of asthma? Here's another from the stamp movement. Anybody in the room will admit to this? Sometimes he makes me feel I want to do that, but yeah. And this one's one of my favorites. I work at the Apple store, and I judge you by which color iPod you pick. All right, so how do we go about and classify asthma? So this kid comes in, 3 years old, had several episodes of shortness of breath. We decide that they have asthma. How you classify it at the first visit? What do we do? What questions do you need to ask? Frequency. Say it a little. Okay, so two of the questions you want to ask are how often are you having symptoms during the day and how often you're having symptoms at night. All right, so what else are you going to ask? Those are two of the questions. What else do you need to ask in a patient?
How often they have to be treated with steroids?
So how often have they been on oral steroids? That's a great one. With the guidelines that came out with the National Heart and Lung Blood Institute, one of the big questions you want to ask is how many exacerbations have you had in the last year? The number of exacerbations that you've had in the last year predicts the number of exacerbations you're probably going to have in the future. So you want to find out how often they have been hospitalized, how many times have they been to the ER, how many times have they been on oral steroids. What else?
How often are you using your inhaler?
How often are you using your inhaler? So that's another one. Are you using it not at all? Are you using it daily? That's going to help classify it. So those are the main questions, and this is the chart. So this is the interesting thing is, and a lot of people don't understand this with the classification. So when the patient walks in to see you the first time and you diagnose them with asthma, you classify them. And this classification, according to the National Heart and Lung Blood Institute, stays with them, okay? So when you classify them as mild persistent asthma, even if they improve, they're still considered a mild persistent asthmatic. So you can see some problems with that. If you see a lot of asthmatics, you know that asthma kind of changes as you go along. But what this is trying to say is, what would their asthma look like at baseline, not on any medications? All right? And again, I think we addressed all these. How often are you having symptoms? If you're having more than twice per week, then you're considered in the persistent category. If you're having nighttime awakenings more than twice a month, you're considered in the persistent category. If you're using your albuterol more than twice a week, you're considered in the persistent category. And then you see the FEV1 measurements. In the guidelines, it recommends trying to start to do spirometry around age 5 or 6. So in age 5 or 6, we're going to look and try to start doing spirometry to help classify these patients. And then one thing we didn't talk about is how much is this affecting your lifestyle? Are you able to do the sports you want to? Are you able to go to school? If you have any limitation at all in those things, then you're going to be in the persistent category. And the thing to remember is, when you classify them, you go with the worst thing. So if they feel like they're extremely limited with the normal activity, then they're going to be severe persistent, even if everything else is in the intermittent category. So you go with the worst category to classify them. Does everybody understand that? All right, let's go to the next slide. One thing that's a little bit different for kids 0 to 4, when you're asking about the number of exacerbations, if you have more than 2 a year, that's going to put you in the persistent category also. So again, if you're not incorporating this in your asthma questions, these are things you really want to find out because it's going to really tell you how severe these kids are. So after you classify them, you want to figure out, are they controlled or not controlled? So your note should really say, this is a 3-year-old black male with mild persistent asthma who is either controlled or uncontrolled. Okay? If they're uncontrolled, what are you going to do? You're going to either increase their controller medicine or start them on a controller medicine. Okay? So that's where this is helping you, is that if you have a patient that walks in your office and you think they're uncontrolled, you need to be making some kind of change in their medical therapy. If they're controlled, you may be decreasing their medicines or decreasing or not starting on something. So that's where this is really helpful. And it's pretty much the same questions. And it's real easy. We make it real easy is that it's a rule of 2. So all these questions are rules of 2. So keep that in mind when you're seeing the patient. So if they're having problems more than twice a week or twice a month at night, you need to be making changes to their controller medications. For age 5 to 11, they add a few things to it, and the main thing is spirometry. So in the asthma patients that are older than age 5, we need to be getting spirometry. The National Heart, Lung, Blood Institute recommend that you get spirometry at least once a year. We don't always do a great job at that with all our patients. So, if you have a patient that maybe doesn't see an allergist or a pediatric pulmonologist, or you don't have access to spirometry, it may be worthwhile just to send them over once a year to get spirometry on them so you can have a baseline. Many of these patients who have asthma have what we call silent asthma. They tell you they're doing great, and I don't know they're having a problem until I get spirometry on them. So I find it very useful, even when they're saying they're doing great, to do spirometry, because you walk in and you find that they have an FEV1 of 60%, and then you have to decide, what are you going to do with that? And we know that the lower their FEV1, the more at risk they are for having exacerbations and problems. So a lot of times if you can adjust their medicines, change their medicines, you can keep them from having problems. Age 12, pretty much same questions. The only thing that really changes at age 12 is you can use the ATAC, the ACQ, or the ACT, which are screening measures. You give them a sheet of paper. When they walk in the office, it asks questions. It puts a score down, and based on that score, helps classify whether they are controlled or not controlled. How many of y'all use those in your office? Do any of you use those? You got a few of them. When you're trying to meet some of these measures for Medicaid and Medicare and all these insurance, this is a good thing to incorporate into your practice. A lot of these insurance companies will accept these measures as things to look at when they're looking at these things. We've talked about this already. To decide whether or not the asthma is controlled or not controlled, Baylor Health rules of 2. And if they answer yes to any of these questions, they're considered uncontrolled. So again, if they're uncontrolled, you need to be doing something about it. One of our goals for this whole CME is that we want to partner with you. Our goal is that in the Charleston area is that kids and adults are going to get better asthma care. And it doesn't matter to me as whether if y'all are doing that or if we're doing that, but our goal is for us to see kids get better asthma care in the city. And if you can, one of my hopes through this talk is that you take something from this and you get better at managing asthma. And when you need help, we're there. But I'm hoping that each one of you learn something where we manage asthma better. So other stuff that can make or can cause exacerbations, poor underlying control is one thing. So again, you have the kid that tells you they're doing great, and they tell you they're using their medications. You check the spirometry, and the FEV1 is 60%. They have poor underlying control. You need to do something about it to help decrease the exacerbations. Do all your kids take their medications? No. Your kids ever lie to you when they come into the office? All the time. I agree. We'll talk a little bit about nitric oxide testing in a little bit, but I call it the lie detector test. I ask the patients, I say, are you taking your medicines? Yes. We check a nitric oxide level. Nitric oxide level, if it's high, tells us, one of the things it tells us is they probably aren't taking their medications. So I go back in the room and I say, look, your nitric oxide is very high. Are you taking your medicines? And they say, yes. And I say, okay, well, how many times a week are you taking your Advair? And you're supposed to be doing it twice a day. Oh, I take it maybe once a day. And then the mom looks at them and says, you tell me you're taking your medicines all the time. You've been lying to me? And again, it's amazing to me how many of the parents trust these 5-year-old and 6-year-old kids to do their inhalers. There's several problems with that. One, you're trusting a 5-year-old to do something, and if you got kids, you probably shouldn't do that. Second, you're trusting that they're doing it right. And so one of the things that I encourage you to do is partner with the parents and work with them and make sure that they're watching their kids doing the medications. Because until they get to a certain age, they probably shouldn't be doing it alone. Other stuff, improper inhaler use. How many of you see how the kids are using their inhalers? Do y'all get them to demonstrate in the office? Great thing to do. Most of these kids probably need spacers for a lot of these HFA inhalers. So if you're not using spacers, it helps increase the lung deposition. So again, get them to demonstrate in front of the office. Infections can cause exacerbations. We already talked about pollution, allergen exposure, smoke. Always ask my patients, does laughing or crying make you cough more? That's a sign that it may be asthma. Exercise, cold air can trigger it. And females, menstrual cycle. You know, do your coughing and shortness of breath get worse at a certain time of month? You know, sometimes that happens with some of these females. And then changes in weather. This is one thing that really changes between managing adults and kids. In kids, the majority of the time, a viral infection is playing a role in their asthma. In adults, it still can, but it's not as common. Other things you want to do in your asthmatics, you want to make sure that they don't have these comorbid conditions. You want to make sure they don't have allergic rhinitis. If their allergic rhinitis is not controlled, then their asthma is not going to get better. Also, do they have chronic sinusitis? We have a lot of kids that come and they're not getting better because they have chronic sinusitis, and you have to treat that before their asthma gets better. Reflux can cause it. Vocal cord dysfunction. Vocal cord dysfunction means that your vocal cords are shutting when they should be open, and it has pretty much the same symptoms as asthma does. They say that maybe 15 to 20% of asthmatics have coexisting vocal cord dysfunction. So if you have an asthmatic who's not getting better, you want to kind of think about this also. And then if they're snoring at night, you may want to look for obstructive sleep apnea. Do any of you have this problem with your spouse? Do you have to go to another room every night to watch TV? No? Okay. And here's another one. Sometimes I put the toilet paper on backwards just to annoy you. So the ones laughing, I think, do that. Okay. Okay. So what testing, would you recommend? Here's some of the testing that we do. So we've already talked about spirometry. We usually get spirometry on asthmatics most visits. Many of my patients I send home with peak flow meters. Peak flow meters are very cheap ways to monitor asthma. So if you have a patient that comes in and the mom says, hey, I never can tell when my child is doing bad. Okay, well, what you should do is give them a peak flow meter and let them monitor their peak flows. And when they're peak, so you can get peak flow meters in the pharmacy. You send a prescription to the pharmacies, and most pharmacies you can get them. It depends on the insurance. Some insurance you get it for free. Some, most $25 to $50 depending on it. Yeah. So, but yeah, you can get those at the pharmacy, and it's very helpful in a lot of patients. At break today, over here in the corner, I brought our Niox machine. It's like spirometry. You blow in this machine, and it gives you a number. It gives you the level of nitric oxide. The higher the level, the more inflammation we think. And that can help, too, in telling how our asthmatics do. But if you'd like to do it yourself to see what your nitric oxide is, I encourage you to do it during the break. We'll have it up there. It's very helpful in a lot of our asthmatics. We have patients that come in and the spirometry is normal, and their nitric oxide level is over 100. And we consider high to be higher than 35 in kids, so it can be very helpful. Skin testing or blood work, again, if you're trying to figure out if this is asthma or not, if they're allergic, much more likely. Also, if they're flaring certain times of the year, that you can help the patient a lot with finding out what they're allergic to by avoiding and also thinking about putting on immunotherapy. Immunotherapy has been shown in multiple studies to help decrease asthma and the symptoms and medications. So a lot of people forget about immunotherapy for asthma, but it works very well for asthma as it does for allergic rhinitis. Kid that comes in that's only having symptoms with exercise, we can do exercise challenges. We put them on a treadmill and do spirometry after exercising. Methacholine challenges we typically use in patients that have normal spirometry but are coughing and wheezing. We're unsure if they really have asthma or not. We do a methacholine and see if it's abnormal or not. Sinus CT if you're concerned about chronic sinusitis. And then if you have a kid that's having a lot of recurrent infections, pneumonias, sinus infections after getting their adenoids out, ear infections after getting tubes in, you may need an immune deficiency workup also. So to get CME credit today, you have to memorize this list by the end of the talk, okay? And we'll test you on the way out, all right? But this is a list of all the different things that can cause wheezing. So most of the time we think wheezing, we think reactive airway disorder of asthma, but there's a lot of different things that can cause wheezing. I want to throw this picture up here. Again, this is my 14-year-old. He'd be very embarrassed today if he was sitting here and me throwing up this picture. But this is one of my favorite pictures of him. And the reason I threw this up here is just that, all these pumpkins are kind of different sizes, different shapes and stuff. And that's kind of what asthma's like, is that when you see asthma, each asthmatic's very different. One asthmatic, allergies may be triggering it. The next may be from being in daycare. The next may be you don't know what's causing it. But it's very different in each patient you see. And so you really have to spend time and individual time to figure out what's going on. So these are some of my final slides. So how do we figure out if it's asthma or reactive airway disorder? This was a study done probably 15 years ago, and they were looking at children with diagnosis before age 3 and things that predicted whether or not this was more likely to be asthma. And so they needed to have at least one of the two major criteria. And the major criteria, if they had atopic dermatitis, that increased their risk for asthma. If they have a parental history of asthma, that increased their risk. And then the minor criteria, they needed 2 or 3. So allergic rhinitis, you check CBC and they have eosinophilia, that increases it. And then if they have wheezing without infection, it greatly increases the risk of having asthma. So that's a question you want to ask. Do you only get asthma when you have a viral infection? So if they're getting it at other times, you're definitely thinking about asthma more. So one of the best predictors of asthma is allergies. And this is from the same study, and what this shows is they split the groups into 3 different groups. You had some patients that came in, and they're called transient wheezers. They have wheezing until from like age 0 to about 5, and it goes away. Those are the ones that, they have it and it goes away. Then you have the non-atopic wheezers, so you skin test them. They don't have allergies. Many of them continue to have wheezing and asthma, but their risk, as you can see, is a lot less than the group that's diagnosed with asthma. And then the asthma group are the ones that typically have more allergies and family history. And in those groups, it's usually more persistent. It doesn't go away. So again, a question you'll get a lot from the parents is to say, hey, you diagnosed my kid with asthma. Is this going to be lifelong? Some of the things you can help predict whether it's not going to be lifelong is, do they have allergies? Much bigger chance that they're going to do it. Mom or dad have asthma? Much better chance that it's going to stay with them. So again, this is the transient infant wheezer. So these were people or kids that had wheezing before age 3. They had a low level of lung function prior to the respiratory infection. This group had no correlation to family history, atopic dermatitis, or allergic markers. So again, if they don't have these things, it's more likely to go away. Their lung function at older ages is slightly reduced. And then when they looked at age 6 and 11-year-olds, many of them didn't have wheezing any longer. In the non-atopic wheezers, 40% of those went on to continue wheezing at older ages. But many, the wheezing resolved by age 11. Their initial lung function was normal when they looked at it. Those with RSV or lower respiratory infection had reversible lung function at age 6 and 11. So if they have RSV, again, that's another risk factor for the asthma persisting. So now, you diagnose the kid with asthma, what are your choices? And I'm just going to run through these real quick so you know, but pretty much we have the National Heart and Lung Blood Institute guidelines. They have step therapy. The first step is always albuterol only. So if they're having symptoms less than twice a week, then you're going to put them on albuterol only. Step up after that, and the recommended treatment is inhaled steroids, and you have about 6 or 7 different inhaled steroids you can choose from. We think they're all about equally efficacious, so what I encourage you to do is pick 1 or 2 that you know how to demonstrate very well, okay? Because that's one of the most important things you can do for the patients, teach them how to use the inhaler. I like spacers, especially if you're using HFAs that do that. Singulair is also another option at that step 2, but they have head-to-head studies with Singulair and inhaled steroids, and in more patients, inhaled steroids tend to work better and are more effective. So does Singulair work? Yeah, it works for some patients, but it doesn't work for as many as that. So usually, in most of the guidelines, inhaled steroids are recommended prior to Singulair. Long-acting beta agonists, they're only recommended to be used in combination with inhaled steroids because of possible increased risk for exacerbations and death. So you should always be using those with inhaled steroids. So you have your Advair, your Dulera, your Symbicort as choices. And then recently, LAMAs have gotten the recommendation for asthma. So your long-acting muscarinic antagonist, so your Spiriva. Spiriva has an indication for 12 and above at this point. So it can be an add-on therapy to some of these other. It's not in the National Heart, Lung, Blood Institute guidelines because the studies hadn't been done when it came out. So when the new guidelines come out, it'll be interesting to see how they position Spiriva in treating asthma. And then just this year, and I actually have a mistake in this, Xolair got the indication for 6 and above. Okay, prior to that it was 12 and above, but now there's an indication for Xolair, which is omalizumab, which is an anti-IgE antibody. So in your severe asthmatics that are on combo therapy and are on Singulair and still having problems, Xolair is a great option for your allergic asthmatics. So it's indicated for patients that have allergic asthma, severe allergic asthma. And typically it's a sub-Q injection, and typically it is given in an allergist or pediatric pulmonologist office. I'm going to wrap it up real quick. So the question is, when do you initiate daily therapy for infants and young children under age 5? So if we have episodes more than 3 times a year, it's typically recommended to get them on a daily therapy, especially if they have atopic dermatitis and perennial asthma. If they have 2 of the following: physician-diagnosed allergic rhinitis, peripheral eosinophilia, or wheezing apart from colds. If they're having symptomatic treatments more than twice a year, or if they've had 2 severe asthma exacerbations less than 6 weeks apart. So that's something you're always going to have to decide is, do I just treat them during their exacerbation, or do they need to be on a daily treatment to keep them from having it? And these are some of the guidelines for doing this. I'm going to skip that. So we'll wrap it up here. The family would kill me if they knew that I swig. Her question was, in a patient with reactive airway disease, would you expect the nitric oxide level to be normal? I don't know if they've done a lot of studies in kids with just reactive airway disease. What we know about the nitric oxide level is a marker of inflammation. So not every person with asthma has an elevated nitric oxide. It's more in patients that we think have eosinophilic asthma. So there can be some patients that come in our office that are doing really bad and the nitric oxide level is normal too. So we really use this test in combination with spirometry. We never, do it separately from doing spirometry. So we kind of use both of them together to kind of decide what to do. Other questions?
What is your go-to in children under 5 for steroids?
I think you have, a lot of options in that age group. I use a lot of QVAR because I like HFAs and like using spacers, so that's one that I like using. But Flovent's a great one. Asthmanex. There's a lot of choices. So really, what I would encourage you is find one that you know how to teach and start teaching it.